Hi there, and welcome to the voiceover PowerPoint for myeloproliferative disorders. I'm Dr. Alex, and this, of course, is the voiceover PowerPoint for the Naturopathic Clinical Laboratory Diagnosis class. So hopefully you're viewing this before you come to class. So what are we going to talk about? Erythrocytosis, the myeloproliferative syndromes known as Polycythemia vera, essential thrombocytosis, and myelofibrosis. So beginning with erythrocytosis, we could define that as an increase in the number of circulating red blood cells per volume of blood. That's synonymous with polycythemia. And we're going to see that reflected in our laboratory values, since, really that's my thing is the laboratory values, reflected as an elevated hemoglobin and hematocrit. All right, and those causes then of erythrocytosis are primary and secondary. Primary would be the clonal Polycythemia vera, and secondary would be also called polyclonal. And we'll talk about what primary versus secondary and clonal versus polyclonal means. So using a cancer model, simplistically, we could say that cancer is a monoclonal disease. And if we wanted to say a little bit more about that, we could say that monoclonal populations come from fields of dysplastic and genetically unstable epithelium. And if we contrasted that with a benign neoplasm and a hyperplasia, those are polyclonal, like inflammatory conditions. So I understand that that's probably still a little confusing, so let's just condense it even further to say that clonality arises from a single cell. So I know you guys haven't had pathology fully. In fact, I think you're at the same place in pathology maybe as you are in this class. And you certainly haven't had oncology, but clonality arises from a single cell. And you can pull out your favorite medical dictionary and look these terms up as well. Clonal versus polyclonal again. So primary or clonal erythrocytosis, which is what we're talking about, erythrocytosis, is the diagnostic feature of Polycythemia vera. And Polycythemia vera is often referred to as Pvera or PV, and it's almost always associated with a genetic mutation that's JAK2 or JAK2. All other scenarios represent secondary. So if it's not Polycythemia vera, then it's a secondary or non-clonal erythrocytosis, often referred to as secondary erythrocytosis. And we're going to see serum EPO levels normal or elevated in secondary erythrocytosis, and we're going to see them subnormal, so the serum EPO levels as subnormal or below normal in Polycythemia vera. So let's look first at secondary polyclonal erythrocytosis. We're talking about a congenital polycythemia that could be associated with high or normal EPO levels, as we said on the previous slide. And I give you one example, which is 2,3-DPG deficiency. 2,3-DPG deficiency. And you may recall the importance of 2,3-DPG in oxygen release and in hemoglobin, and in terms of, you may remember from biochemistry that, when you go from sea level to altitude, DPG has to increase in order for the difference in oxygenation in the body to be efficient and the person not to notice it. And so one example of congenital polycythemia could be as a result of 2,3-DPG deficiency. All right, low EPO levels are also another example, another reason for congenital polycythemia associated with activating mutation in the EPO receptor. So it's a congenital reason that we have low EPO levels, and then we end up with a polycythemia as a result. So then we'll talk about what's an acquired polycythemia. And an acquired polycythemia, and when we're talking about secondary or polyclonal erythrocytosis, could be EPO mediated. So this could be, again, high altitude. Someone goes to high altitude, or they have a chronic lung condition. This would be an example of hypoxia-driven, a hypoxia-driven acquired polycythemia. We could also have a hypoxia-independent. So now it doesn't have anything to do with hypoxia, but then we're talking about pathologic EPO production, as might be seen in a malignant tumor. We could also have drug-associated EPO and androgens resulting in an acquired polycythemia. So we didn't have it as a genetic thing, but now we have it as a sequelae to certain drugs, EPO, blood doping, and androgen intake. So polycythemia vera then, the definition of polycythemia vera is, or primary clonal polycythemia, is a neoplastic disorder arising from that pluripotent stem cell, which you all should remember from multiple times we've discussed the pluripotent stem cell. And this is generally characterized by erythrocytosis with or without thrombocytosis and leukocytosis. So you can have an absolute increase in your erythrocytes without an increase in your thrombocytes or your leukocytes. Okay? Or you could have it with an increase in your thrombocytes and your leukocytes. There's 10, incidence is 10 new cases per million people, and I'm going to go with annually. And highest incidence in ages 50 to 75, but 5% of these polycythemia vera cases occur in patients less than 40 years old. And so if we looked at the stages or the phases that are important in the condition known as polycythemia vera, clonal polycythemia vera, primary polycythemia vera, we're talking about a clonal primary erythrocytosis known as polycythemia vera. And the initial disease period is the proliferative phase. So in the proliferative phase, if untreated, most patients with polycythemia vera are going to die within months of some kind of vascular complication. But maintenance of the red cell mass somewhere near normal by either phlebotomy, I'm taking out some of those red cells, or chemotherapy, I'm going to kill some of them off, allows for long-term survival. And long-term is defined as 7 to 10 years, which, you know, that doesn't sound like a very long time to me, but it is in this case. End-stage polycythemia vera is referred to as the spent phase. So proliferative phase versus the spent phase. And what's happening in the spent phase is usually splenomegaly and hypercellular myelofibrosis and myeloid metaplasia. So what does that even mean? Well, we're going to talk about what that means. But suffice it to say that something is changing in the bone marrow, and now fibrotic tissue is getting regular blood cells are getting replaced by fibrotic tissue, fibrosis, and myeloid metaplasia. Something is moving where it shouldn't be. This is sometimes called post-polycythemic myeloid metaplasia, and about 5% of people are going to die from that. So what's the natural history of polycythemia vera? Well, again, here's the latent phase, which is asymptomatic. We didn't mention that on the previous slide because it's asymptomatic. The proliferative phase, and this is where patients may be hypermetabolic or have signs and symptoms of hyperviscosity of the blood, which would, also be thrombotic events, thrombosis in the blood. And then the spent phase, and what do we define the spent phase as? Well, that's kind of the end stage where we've got splenomegaly, hypercellular myelofibrosis, some bad things going on, okay? In the spent phase, you have anemia, leukopenia, secondary myelofibrosis, and increasing in liver and spleen size to try to, especially the spleen, trying to keep up. So secondary AML, will occur in 1 to 2% of patients treated with phlebotomy alone, and certain drug therapies increase the risk of the conversion of, well, I wouldn't even call it a conversion, I would say it's a secondary condition that occurs from polycythemia vera. And I know you've all studied AML with Dr. Acosta-Smith. So polycythemia vera symptoms, the symptoms common to all erythrocytosis, a headache, a decrease in mental acuity, weakness, and they're more specific to polycythemia vera, or the signs and symptoms more specific to polycythemia vera and myeloproliferative disease in general, interestingly, would be pruritus after bathing, erythromelalgia, which we're going to define here in just a second, and hypermetabolic symptoms, thrombosis, and hemorrhage. Okay, so in this erythromelalgia is defined well for you on a future slide. So hold on to that thought and let's keep going because I only have like 7 more minutes to finish this. So polycythemia vera physical exam findings. We will see a facial plethora, splenomegaly in about 70% of the patients, so that's a pretty good one. Hepatomegaly in 40%, and distension of the retinal veins. Lab findings, we're going to see an increased hemoglobin hematocrit, an increase in the white cells, an increase in the platelets, 65%. Basophilia seen in all myeloproliferative disorders. we're going to have an increase in uric acid and B12 and an increase in leukocyte alkaline phosphatase score, and then we're going to see low EPO levels. And when you look at the PowerPoint posted without the voiceover on your Moodle site, you might sit down with a pencil and a piece of paper and try and figure out why these are what they are so we can talk about them in class. The treatment is phlebotomy first. We also, in medicine, use myelosuppressive agents, so things that suppress the bone marrow. Hydroxyurea, alkylating agents, and then interferon alpha. I want to just mostly talk about phlebotomy because generally this is the best initial treatment for polycythemia vera. There's no increase in the progression to AML, rapid onset, and no bone marrow suppression. So it's pretty innocuous treatment. So you remove 500 cc's of blood 1 to 2 times a week to target the hematocrit at 45%, and then you maintain. And the downsides, you have an increased risk of thrombosis, no effect on progression to the spent phase, and it may be insufficient to control the disease. But hey, it's a pretty much no risk to try it. So other than that, increased risk of thrombosis. But if you're going to have almost no chance of survival otherwise, I say why not try it? And that's, in fact, what is the first line. So essential thrombocythemia is next. So essential thrombocythemia. And essential thrombocythemia is an uncommon disorder in which your body produces too many blood platelets. So now we've gone to polycythemia to essential thrombocythemia. Okay? So, and this is, again, thrombocytes increased. So it's also known as primary thrombocythemia. And the exact cause of essential thrombocythemia and similar conditions known collectively as the myeloproliferative neoplasms, I got too many things proliferating in my myelo, isn't known, but half of the people who have these have gene mutations. So essential thrombocythemia, only 50% of these have a clonal disorder. The rest have polyclonal increase in megakaryocytes. And the incidence is similar to polycythemia vera. 20% of patients are less than 40, and the exact pathophysiology is not clear. How do we diagnose this? Well, first we rule out secondary causes of thrombocytosis. Too many thrombos in my site. So I've got too many platelets in my blood, right? So cancer, infection, inflammation, bleeding, iron deficiency, all these things could be secondary causes of thrombocytosis. I mean, you don't have to have essential thrombocytopenia. Let me say that again, essential thrombocythemia, just because you have thrombocytosis, okay? You can have other reasons for this. Patients may have splenomegaly. The platelet count should be greater than 600 on 2 separate occasions at least 1 month apart. It's a diagnostic feature. And you should exclude CML by the absence of the Philadelphia chromosome. And you should exclude polycythemia vera by a normal hemoglobin without iron deficiency. And so the natural history rarely progresses to AML, less than 1%. And again, this may lead to myelofibrosis, and the major complication in ET is thrombosis. And this occurs in 20 to 30% of patients, and the clots can be arterial or venous, so it's kind of a bad deal. So essential thrombocytosis, let's go back here and look at this. Essential thrombocythemia, okay? The labs. Let's see, I think I skipped symptoms. Natural history, yep, and symptoms. Many patients are asymptomatic at the time of diagnosis. Digital ischemia from microvascular thrombi may be present. And then here's this erythromelalgia, redness, throbbing, and burning pain in the hands and feet. We have pruritus, and then we have hemorrhage seen in 40% of patients. So what are our labs? Iron studies should be normal, as the sedimentation rate should be normal, which is a measure of inflammation. And the platelets can be very large and bizarrely shaped. The marrow shows clusters of abnormal megakaryocytes, and 50 and some sources say 70% have that JAK2 genetic mutation we talked about earlier. And here again is the abnormal megakaryocytes. All right, arrows indicate some of the abnormal megakaryocytes. Pretty interesting, unless you're talking about your own blood, and then it's probably just depressing. And then ET treatment targets reducing the platelet count. And whom to treat is somewhat controversial, and in general, we treat those who have had or are at risk for thrombosis. And that would be also people greater than 65 years old or patients with platelets that are 1 to 1.5 million. Why treat? Because in patients at risk for thrombosis, treating reduces the risk and maybe secondary myelofibrosis. So we definitely want to treat this in those patients. And then what would happen if it were to progress to myelofibrosis? Well, myelofibrosis is a serious bone marrow disorder that disrupts your body's normal production of blood cells. The result is extensive scarring in your bone marrow, leading to severe anemia, weakness, fatigue, and often enlarged liver and spleen. And it's actually a type of chronic leukemia. And then what is that? A cancer that affects the blood-forming tissues in your body. So myelofibrosis can occur on its own, which is primary myelofibrosis, or it can occur as a result of other bone marrow disorders, and that's going to be secondary myelofibrosis. And myelofibrosis occurs when a genetic mutation occurs in the blood stem cells. So blood stem cells have the ability to replicate and divide into the multiple specialized cells that make up your blood. We know this. We've seen this. We can have red blood cells, we can have white blood cells, and we can have platelets. So something goes wrong. Myelofibrosis is also called myeloid metaplasia with myelofibrosis, and it's a clonal stem cell disorder, again, that affects the megakaryocytes predominantly. So think about where the megakaryocytes are in that chart. Pull that chart out that has all the, I start with a pluripotent stem cell and I end up with whatever it is I want. And find megakaryocytes, and that's your clonal stem cell disorder that affects them. All myeloproliferative disorders can result in the spent phase. And we talked about what the spent phase is, which can be difficult to distinguish from primary myelofibrosis. So you might end up with a secondary myelofibrosis as a result of another condition that we talked about previously. Myeloid metaplasia refers to early proliferative phase where extramedullary hematopoiesis predominates. So what does that mean? Myeloid metaplasia, okay, we can say in some cases myelofibrosis and myelometaplasia with myelofibrosis are synonymous, so we've got that. Now what about just myeloid metaplasia? So if we're talking about myeloid metaplasia, we're talking about an earlier proliferative phase, remember the proliferative and the spent, and extramedullary hematopoiesis predominated. And what happens when extramedullary hematopoiesis predominates? Well, we're having the extramedullary hematopoiesis is happening like in the spleen, for example, and the spleen is enlarging as a result, and this would be myeloid metaplasia at this point. All right, so myelofibrosis, natural history and symptoms. The natural history is the median survival is 5 years, and it transforms to AML in 5 to 20% of people, and the symptoms are greater than 50% of patients present with symptoms of anemia and thrombocytopenia. Patients may have fever, sweats, and weight loss, and as the spleen enlarges, the extramedullary hematopoiesis that we were talking about earlier, patients start to have abdominal pain and early satiety. So my spleen is enlarging because it's being used to make blood cells. The hematopoiesis is happening now instead of in my bone marrow. It's happening in my spleen. So my spleen enlarges, and now I have stomach pain, and I'm not able to eat as much because it's taking up space where my stomach used to be able to expand, and it's early satiety. Physical findings: massive splenomegaly and hepatomegaly. Lab findings: early on, patients may have increased platelets and normal hemoglobin and white blood cells. Anemia and decreased platelets and decreased white blood cells happen as the disease progresses. And your peripheral blood smear is going to show leukoerythroblastic picture. So you're going to have teardrops, nucleated red blood cells, and early granulocytes. And you might see something called a dry tap, or an inability to aspirate liquid bone marrow if you were to send the patient for a bone marrow tap. And then increased collagen and reticulin fibrosis is seen on that bone marrow biopsy. 40 to 75% have the JAK2 mutation. Here's some pictures, pathologic features of peripheral blood and bone marrow in patients with myelofibrosis and myeloid metaplasia. And how do we treat it? Well, there's no definitive treatment. If the patient is young, a bone marrow transplant can be done, but the older patients have too high of a mortality for that. So typically the treatment is supportive with transfusions. Splenectomy can be done for symptoms of abdominal pain, but frequent complications of thrombosis, hemorrhage, infection ensue. So understand the definition, etiology, lab tests, and general terms associated with these myeloproliferative disorders, and write your questions and ask in class or via email. I think there was one point in here in this recording that I may have to go back and put a little bubble in. So look for that. I believe I misspoke one thing because I'm trying to go really fast. Perhaps I corrected along the way. I can't really remember. So I'll go back and listen to this. But if you have questions, please write those questions and ask them in class or via email. And once again, have a great day and thank you very much.